In this chapter, we're going to talk about neonatal and pediatric mechanical ventilation. There are essentially three goals of mechanically ventilating a newborn or pediatric patient, really any patient, which is to normalize and maintain blood gases, prevent iatrogenic complications such as barotrauma, infection, sedation, and then to support the patient's respiratory needs. So any of these or a combination of these may be the reason why we choose to put a patient on a vent, even neonates and pediatric patients. We need to consider with blood gases if a patient is in impending ventilatory failure versus being in respiratory failure. Either one of those two situations will lead us to suggest or go ahead and start the process of putting the patient on a vent. If we know that a patient could be at risk for barotrauma or some type of infection, or due to the fact that they're going to be sedated, then we may put them on a vent to prevent those things from occurring. And then if a patient, for whatever reason, cannot maintain their own airway or is not breathing adequately, so they don't need to necessarily be apneic, but if their respiratory system needs to be supported, which kind of goes back to the first bullet, because that would be represented in your blood gas values by a patient who is in impending ventilatory failure or in respiratory failure. But either way, the NBRC can use any of these goals in a scenario, can present a scenario which you would choose any one of these three goals as your reason for putting the patient on a vent. Okay, there is a difference between how we ventilate neonates versus how we ventilate pediatric patients. With neonates, we will use time-cycled pressure limited ventilation. That's important. NBRC will ask you that in some format. So we limit the amount of pressure that we are using to deliver the breath, and we are using time to cycle the breath on and off. With pediatric ventilation, it is just like what we do for adult ventilation, and that would be volume cycled. So we set a volume, we set a rate, and that is how we are ventilating our pediatric patients. The rest of this lecture is going to go more into neonatal ventilation. We'll talk very briefly about pediatric ventilation, and the reason why it's going to be brief, simply because you already know about using volume cycled ventilation. We're just going to talk about the specifics where the values that we use to set volume and such, what those values are in comparison to adult ventilation. When ventilating a neonate, the following are a list of settings that you will put in yourself: PIP, PEEP, frequency, eye time, MAP, and tidal volume has a star by it because it depends on what ventilator you're using, whether you will be able to have that functionality of setting or guaranteeing a tidal volume. The measurements that you will get from the ventilators are things such as tidal volume and minute ventilation. We will go more in depth into each of these items listed here on how to set them and what ranges you should be considering when you have a neonate that needs to be ventilated. With peak inspiratory pressure, most neonates that you're going to be ventilated, you'll be using time cycle pressure limited ventilation, which simply means that you're going to limit the peak inspiratory pressure that you set on the ventilator. So you're going to actually set a PIP, and that PIP is going to tell the machine to not go over that pressure when it is delivering the breath, regardless of whether it has reached that time or not. So the timing is related to how long you're going to be spending on inspiration. So your initial PIP is set to achieve good chest excursion. That's how we will determine whether the PIP is not high enough or whether it's too high. Excessive PIP may cause hyperinflation, as you should know, and barotrauma. So the conditions that we will talk about later in relation to neonates on ventilators are conditions such as PIE, pulmonary interstitial edema. Pneumothorax is another. Of course, you already know what a pneumothorax is. Pneumomediastinum, you already know what that is. Pneumocardium, you should know what that is. And BPD is bronchopulmonary dysplasia. So since you already know about the pneumos, whether it's in the thoracic cavity or in the mediastinum or around the heart, we will touch on those very briefly, but PIE and BPD we will talk about extensively when we get to the next module. When controlling pressures, the PIP directly affects your tidal volume, and it also affects the mean airway pressure. So just remember, when you increase your PIP, you are increasing your tidal volume. So depending on what level you have your PIP set at will determine whether you utilize the PIP to increase ventilation or not. So if you have a blood gas and it states that the patient is hypoventilating and you want to ventilate them more, if their PIPs are not set too high, then you can manipulate the PIP. If your PIP is already set at a high level, then you want to consider manipulating your time. So PIP is the first go-to setting when you are talking about changing ventilation, whether to increase it or decrease it, because it directly affects tidal volume and also affects your mean airway pressure. So if you increase PIP, this will also increase your PaO2 and decrease your CO2. The reason why increasing your PIP affects oxygenation, such as your PO2, is because it is directly affecting your mean airway pressure. So anytime you go up on the mean airway pressure, you are oxygenating better, and therefore the PaO2s will increase. So increasing your PIP will increase your PaO2 and will decrease your CO2. And the reason it decreases your CO2 is because it increases minute ventilation. And the last little part of that bullet states that PIP also increases MAP, which was really stated in the previous bullet. PIP does not affect your IE ratio or your I time. That is extremely important for you to remember. It does not affect the IE ratio, and it does not affect your I time. Okay? So when you are manipulating PIP, whatever your IE ratio was before you went up or down on the PIP, it's going to stay the same. Whatever your I time was on the ventilator, If the only thing you did was adjust the PIP, then the eye time is going to stay the same. PIP does not affect IE ratio or eye time. And this does not have anything to do with neonatal ventilation. This is PIP in general. If you had an adult patient that you were using pressure control to ventilate them with, this same theory applies. PIP does not affect your IE ratio, nor does it affect your eye time. With positive end expiratory pressure, otherwise known as PEEP, it is the positive pressure that is kept in the airway during the expiratory phase of ventilation. Figure 14-2 in your textbook gives a good depiction of the positive pressure that's kept in the lungs during expiration. It shows that the breath never goes back down to baseline. It starts at the pressure that you have set for PEEP, and then it shows the inspiratory pressure, that the actual pressure on inspiration, which is obviously your PIP, and the difference between those two numbers are really what you're ventilating the patient with, not just your PIP setting. So if you have a PEEP of 5 and a PIP of 30, you're really just ventilating the patient with 25 of pressure. Hopefully that is not new information to you, and you already understand that concept. But these figures 14-1 and 14-2, are a good depiction of what is actually going on with positive inspiratory pressure and your positive end expiratory pressure. So PEEP prevents alveoli from collapsing, and of course that increases your functional residual capacity, because the functional residual capacity is simply what is left in the lungs at the very end of expiration. So ideally, plus your residual volume. That's the amount that you will never be able to get out of your lungs, because that was set when you took your very first breath. So PEEP will prevent the alveoli from collapsing, obviously, but it also does increase your FRC. So keep that in mind. PEEP may improve oxygenation and compliance. That is why when patients have low compliance or stiff lungs, we can incorporate higher levels of PEEP than those babies who don't have problems with compliance. So your preemies, your babies with RDS, those are the patients where you will see the MBRC try to push the limits with you on PEEP, giving you numbers that probably clinically you've never seen, or you won't see when you do your NICU rotation. However, on the MBRC exam, you never withhold care as long as it is within your limits, not hospital limits, but physiological limits. When a patient has low compliance, you can push the limits with PEEP, because they need it. They need the PEEP because their lungs are so stiff. They need something to keep it open so that they can have that increased surface area, to have diffusion take place, to increase their PaO2 levels, to help with ventilation. So as we stated on the previous slide, PIP helps with that mean airway pressure, but PEEP is going to also help improve oxygenation, because it will keep the lungs open at the end of the expiratory cycle. And it also helps with compliance, because it helps keep everything open so that you don't experience, or the baby doesn't experience, atelectasis. So because you are utilizing PEEP, it allows for lower levels of PIP to be incorporated. And also, you don't have to have very high rates as well. So with PEEP, because I mentioned earlier the difference between your PIP and your PEEP is what you're really ventilating with. If you have a baby who has compliance problems because you can incorporate higher levels of PEEP, you then don't have to use the same PIP level that you were using previously before you went up. So you say you have a patient who is very hard to ventilate and you don't have them on very high PEEP levels. If you find that they're having problems being ventilated simply because they are having compliance issues, then if you increase your PIP, you will find, because you start off with a much larger alveoli, it's easier to get them to the max capacity of that alveoli because you already started off with an alveoli that had some room in it. Hopefully you remember that from last semester, actually first semester, when we talked about time constants and things of that nature. So if you already start off with the alveoli that is already full or has already started to fill because you never let it get down to baseline, then it doesn't have far to go to get to its filling capacity. Okay, PEEP amounts vary per MD order. So when you are working in a hospital, they will have their protocols in place, and you should be following the hospital's protocol. Don't go to the hospital talking about, well, the MBRC says we can put a PEEP all the way up to 8. Well, that may not be that hospital's protocol, but you need to remember the tests way. You got to have on your test hat when you're in the test environment and have on your clinical hat when you're in the clinical environment. Okay, so the PEEP amounts vary per MD order, but in neonates, we try not to go over 6 to 8 centimeters of water, depending on the size of the neonate. The smaller the neonate, surprisingly, you can go higher on the PEEPs, you would think, because they're so little that we're concerned about barotrauma, but you're really not. Their lungs are so stiff that we're not as concerned about barotrauma with them as we would be for patients who are term. So when controlling your pressures, if you are not manipulating your PIP, so PIP is held constant. If you increase your PEEP, you decrease your tidal volume. That should not be new information to you. This is all information that you've already learned when you were learning about adult ventilation and pressure control. Even when we talked about BiPAP, you learn this concept, because if you increase your EPAP, but you don't increase your IPAP when you're using BiPAP, you decrease your tidal volume. So again, hopefully this is a review for you. Those of you who are finding this information new, that's concerning. It should not be new information to you. All right, last bullet says high levels of PEEP may lead to increased dead space and decrease cardiac output. Again, this is not new information. You should already understand these concepts. When you have high levels of PEEP, you do not give room or make way for there to be a lot of time to get that breath, to complete that breath, and therefore the next breath you end up with all of that dead space that was not used for ventilation. It didn't have time to get down to the alveoli because you kept so much pressure in there from the previous breath a lot of that ventilation that you just took in on that current breath didn't make it down to the alveoli. It stayed in the conducting airways. And that's why when you do have high levels of PEEP, not everything that you inhale gets down to the alveoli. That is why you have increased dead space when you use high levels of PEEP. It can lead to increased dead space. And the last thing about cardiac output, hopefully it makes sense to you that when you have high levels of PEEP, you will cause there to be more pressure in the thoracic cage, therefore causing vasoconstriction, thereby causing the heart not to be able to kick out as much as it normally does, because that increases afterload, and the heart would have to work harder to overcome that. But if it did not, if nothing else changed, but you increased your level of PEEP, immediately the change in this cardiovascular system would be a decrease in cardiac output. Subsequently, you would have a compensatory response to where the body would, or the heart and the blood vessels would try to overcome that increased afterload by beating stronger or faster to overcome the resistance downstream due to the vasoconstriction, simply because the barotrauma due to the high levels of PEEP. Hopefully everything I just got through saying to you is second nature at this point. If it is not, you need to go back over some things, because it should be. For the rate or frequency, you need to be aware that it will influence your IE ratio, unlike your PIP that we talked about earlier, because that does not affect your IE ratio. But of course, your rate or frequency does, because it determines the time interval between the beginning of each breath. In other words, your total cycle time. Your total cycle time is a component of the rate. You achieve your total cycle time depending on the rate that is set. And you should already know how to calculate total cycle time if you know what the patient's rate is. You need more information. We won't belabor that. Something you should already know. So you calculate your total cycle time by knowing your frequency and the other magic number, which you should know what that magic number is, in order to determine what your total cycle time. Alrighty. I'll just go ahead and give you a hint. It's how many seconds are in a minute. Okay. The frequency directly affects your minute ventilation, CO2, and your mean airway pressure, which is denoted as MAP or PAW. So since it directly affects those three things, if you increase the rate or the frequency, you also increase each one of those things listed as well. So if you increase the rate, you increase your minute ventilation. If you increase the rate, you increase the amount of time that you are ventilating. And therefore, if you are ventilating more, you decrease your CO2. When you increase your frequency, you also increase the amount of pressure in the average amount of pressure, which is your MAP, mean airway pressure. And a mean is the average of anything. So the average pressures in your airway. And that can either be signified as PAW or MAP. So high rates are reserved for patients with compliance problems, and we will talk more about the neonates that have these issues, or infants and neonates, not just neonates. So you know the difference between a neonate and an infant. A neonate is someone who has never left the hospital and was born, and they have been here ever since they were born. An infant can be a day old, a day from being discharged from the hospital, rather. So they were in the hospital a couple of days, and now they go home, and baby gets sick and comes right back. That is considered an infant, not a neonate. There's a difference. Nonetheless, RDS, which is respiratory distress syndrome, sometimes signified as IRDS, and bronchopulmonary dysplasia. Those are two examples of conditions that will cause the patient to have an decreased compliance. When your compliance is decreased, that means that you cannot expand your lungs properly. And therefore, in order to ventilate you better, we will have to increase the rate. So RDS makes stiff lungs. Bronchopulmonary dysplasia is another condition we will talk about later that presents itself with stiff lungs. So whenever you do not have the ability to expand your lungs properly, that means your compliance is decreasing. And the way that we offset that is to increase the rate. High rates are also used to treat conditions such as PPHN, which is persistent pulmonary hypertension. For these patients, we want to hyperventilate them, which is what we're doing when we're increasing the rate, so that we can overcome the fact that the pulmonary vasculature is persistently constricted, just like it was when the baby was in the womb. So we hyperventilate those patients as well. Okay, inspiratory time is next, and we set that to cycle off the inspiratory limb of the breath. So how long do you want to spend sending the breath in for the patient? So you set a pressure limit. That is the maximum amount of pressure that you are going to allow that machine to use to deliver the breath. And the I time is how much time you want to spend on the inspiratory limb of that breath. So I time directly affects your mean airway pressure, or your PAW, plateau pressure, and your intrapleural pressures. So since I time directly affects those things, when you increase your I time, you will increase your MAP. Very important. Increasing I time helps with oxygenation in that regard. When you increase your I time, you also affect the hemodynamic pressures and the venous return, which is very important. Hence, why the bullet stated that when you manipulate your I time, you directly affect your plateau pressures and your intrapleural pressures. So if you affect those pressures within your thoracic cage, a thoracic cavity, you will also affect the structures within it. And as you know, the heart is one of those structures. So it will affect the pressures hemodynamically, and it will also affect the blood return back to the right side of the heart. So I time, along with your rate, will determine your IE ratio. Finally, something that helps determine the IE ratio, just as we spoke about with your frequency. As ventilator rates increase, I times should decrease. Very important concept to understand, because if you don't, if you're not mindful of the amount of time you have set for I time, if you have a vent where you can manipulate the rate as well as manipulating I time and E time, then this could cause you to have air trapping. Because if you have a rate of 20, then your total cycle time is 3, right? If you have your I time, just throwing out crazy numbers here, if you have your I time set at 2.5 seconds, that means you only have 0.5 seconds to spend on expiration. So because you don't have enough time to get all that air you just put in there out, you could cause air trapping. And of course, if you trap air, you put the patient at risk for barrel trauma. So be mindful that as you increase the rate, that's going to, let me be more realistic with pediatric patients. So say the rate is 60, then your total cycle time is 1 second. If you have your expiratory time set at 4 seconds and your inspiratory time set at, 0.4 seconds, and your inspiratory time set at 0.6 seconds, then you're good, right? But say you had your I time set, say your previous rate was not 60. Say your previous rate was 30. That means you have 2 seconds to spend on each breath. And if your I time was set at your E time was set at 0.4 seconds, that means you had 1.6 seconds to have dialed in on your I time. Well, if the doctor then says go up to a rate of 60, if you don't go and change your I time, if you keep that 1.6 second I time, you would not have time at all for exhalation. Actually, the vent wouldn't know what to do, wouldn't be able to cycle on because cycle into expiration because your time is too high. So you have to be mindful when you have a patient on these neonatal vents, that if you have an opportunity to manipulate the rate knob, then you need to be mindful of your I time, because if you do not give the patient enough time to exhale all of that stuff that they just put in their lungs, then it could cause air trapping and barrel trauma. Last bullet says the same thing. So if you don't decrease the I times with high rates, you actually may have an inverse ratio. You could be spending more time inhaling than you are exhaling. And you know the expiratory limb should be 2 times that of your inspiratory limb. Mean airway pressure, as you know, is the average pressure in the airways over a period of time. Your MAP is your most powerful influence on oxygenation. So as MAP increases, so does your PaO2. So if you have a problem with oxygenation, as you are aware, the things that influence your MAP will also increase oxygenation. You can adjust the MAP by adjusting the things that you already know: PEEP, PIP, I time, rate, and also flow can affect your mean airway pressure, especially in neonates, simply because their tubes are so small. The more flow you have going through there, the more it will affect the pressures that are in the airway. So to a small degree, flow can make a difference in your MAP. PEEP is most effective, however, So if you were to have a test question that asks what is the most effective way to adjust your map, that would be PEEP. And then PIP is the second most effective way to adjust your map, because map is measured, it's not a setting. It is something that you set other things which will allow you to read your map. And then your IE ratio would be the next in line for one of the things that can be most effective on your map. And the way that the IE ratio is effective in adjusting your map is because your IE ratio is a component of your I time and your rate. So if you change either one of those, you will change your IE ratio, which will then change your map. Map should be kept less than 14 centimeters of water, and this will help prevent barotrauma. It also helps with hypoperfusion. As we just talked about in the previous slide, the more pressure you have in the thoracic cage, the more likely you are to have vasoconstriction. And when you have vasoconstriction, you end up with low circulation or less circulation, decrease in your circulation, which will then decrease your perfusion. And if you are decreasing the amount of blood available to be circulated, therefore you will decrease your cardiac output. There's a note here, it says decreasing your E time will increase your mean airway pressure or your PAW. Very important to understand that. As you decrease the amount of time that the patient has to exhale, this actually increases the mean airway pressure because now you have more time on the inspiratory limb. The longer you're spending keeping the alveoli open, the more you have for average pressure, mean average pressures. As you know, tidal volume is the amount of gas inhaled in a single breath. In time-cycled, pressure-limited ventilation, tidal volume is not set. That should not be new information to you. As you know, if you are setting pressures, you are not setting volume. It doesn't change because you're dealing with the neonate. Concept's still the same. So you can assume that there is adequate tidal volume when there is appropriate chest rise. So although you're not setting tidal volume, you're setting your PIP. We look at the chest rise to determine if the patient is getting a good tidal volume. If they are coming up off the bed with each breath, then obviously your PIP is too high, and therefore your tidal volume is too big. If you barely see the chest rise with each breath, or you see no chest rise, then obviously your tidal volume is too small because the PIP that you set is too small. It goes on to say when there is appropriate chest rise, good breath sounds, and acceptable blood gas values, that lets you know that you have an adequate tidal volume by way of your PIP. So not just a chest rise, that's a good beginning indicator, but we also want to listen. Anytime you intubate someone, you want to listen to their breath sounds, make sure they're equal and bilateral. And then you also want to get a blood gas to confirm that what you have set is adequate for that patient. Be mindful that tidal volume is directly affected by setting the PIP and your PEEP. Don't forget that. I talked about that earlier. So if you increase your PIP, but you don't increase your PIP, Let me do that again. If you increase your PIP, but you do not increase your PEEP, your tidal volume will go up. If you increase your PEEP, but you did not increase your PIP, then your tidal volume will go down. If you increase both of them, increase your PIP and your PEEP, it depends on how much you're increasing them by. That's the key. But say you increased your PIP from 20 to 30 and you increase your PEEP from 5 to 6, then your tidal volume will increase. But if you increase them by the same amount, you will not see a change in tidal volume. So say your PIP was set at 20 and you went up to 25, and say your PEEP was set at 5 and you went up to 10. Because you increased your PIP and your PEEP by 5, you will not see a change in the tidal volume. Okay? So most typically, you do not make both of those moves at the same time. You usually will be choosing one over the other. Either we're going to make a change to affect ventilation and then get a blood gas, or we're going to make a change to affect oxygenation and then get a blood gas. In the MBRC hospital, you will never make two of those changes at the same time. You will never be given an option to manipulate something to affect ventilation and oxygenation. I'll say most never, because there may be those one or two incidences where someone will say, hey, I had a test question and they actually asked me to do both. You always want to focus on those 4 life functions. Ventilation is first and foremost. So if you have a problem with ventilation, look for the option that will allow you to manipulate ventilation. If they are going to give you both options, then they won't give you ventilation by itself, oxygenation by itself, and then an option for ventilation and oxygenation. If they want you to make both changes at the same time, that's the only option that they're going to give you regarding that. So back to my increased PIP and increased PEEP scenario. If you needed to increase your PIP and your PEEP because they were having ventilation and oxygenation issues, they would have all the other options where maybe you're decreasing ventilation or decreasing PEEP. And the only good one answer that they have for you is to go up on your PIP and up on your PEEP at the same time. That is the only time that you would choose that type of option on the MBRC exam. Now, clinically, yeah, we go up on PIP and PEEP all at the same time. There's no rhyme or reason, depends on your facility. But for test purposes, the MBRC very rarely will give you an option to fix ventilation and oxygenation in one fell swoop. They usually want you to do one thing at a time and then check it to see how effective it is before going on to the next thing. Okay, nothing new here with minute ventilation. Minute ventilation is simply the tidal volume times your respiratory rate. And as tidal volume increases due to adjustments in either your PEEP or your PIP, but you have not made any other changes, minute ventilation will increase. So remember, you cannot directly make a change to tidal volume unless you're in volume guarantee. Therefore, tidal volume changes occur because you are either manipulating your PIP or your PEEP. That goes back to the conversation we had regarding going up or down on your inspiratory pressures or going up or down on your expiratory pressures, because the difference between the two is what you're ventilating with. So if you increase your rate while tidal volume remains unchanged, so you haven't changed anything regarding PIP or PEEP, but you have changed your rate, then minute ventilation will also go up. So increase your rate, tidal volume remains unchanged, minute ventilation will also increase. Not new information, just revisiting the concepts here. Flow is the amount of speed used to deliver a tidal volume, as you already know. It does not affect your IE ratio. It influences pressure wave patterns, so it affects the rise time. And that is shown in your textbook on page 457. Down at the bottom, figure 14.9-9, it shows the flow rate form, pressure over time. Yeah, pressure over time. And it shows how, depending on what your flow is set on, it will determine how that waveform looks. So if you increase the flow, it's going to get to that set pressure faster. If you decrease the flow, that means it's going to spend more time getting to the set pressure. So the waveform is going to have a slanted look. It's going to rise, take a longer time to rise to the pressure. It directly affects your MAP, which is also your paw, and which is mean airway pressure. So as you increase the flow, you increase your mean airway pressure or your paw. And then increased respiratory effort and wide volume inspiratory flow increases respiratory effort, and wide volume or pressure fluctuations indicates inadequate flow. So if you have a patient that needs more flow, you will see a change in their respiratory effort. So if they seem like they are air hungry, even neonates, they seem air hungry, if you increase that flow, they should go back to looking normal. So you're not changing any of the settings that the doctor gave. You just increase that flow, and the patient will look more comfortable. Increase flows to increase your ventilation and reverse atelectasis. So we utilize flow to help ventilate the patient better and to pop those airways open, especially for neonates because their airway is so small. The more flow you have, the more you will overcome that airway resistance, and therefore they'll ventilate better. And because you've overcome that airway resistance, you'll be able to get more down into the alveoli and be able to pop it open. Inadvertent PEEP is an indication that you have too much flow. That's a very important thing to know about neonates, because if you notice that their PEEP levels are higher than what you have set, it's probably because you have too much flow set on the ventilator. If flow is set too low, though, the present inspiratory pressure will not be reached before I time ends. You need enough flow in order to get to the set pressure. So if you notice, that's troubleshooting technique here. If you notice that the patient is not, that the machine is not able to get to the set pressure with each breath before it cycles into expiration, it's because you have the flow set too low. Okay, opening and driving pressures are important to know with neonates because it really affects how well you're able to ventilate the baby. So your opening pressure is the amount of pressure required to keep the alveoli open at all times so that it doesn't collapse and you get atelectasis. Driving pressure, of course, you know, is the difference between where you're starting from and where you're going. So where you're starting from is your PEEP, and where you're going is your PIP. So the difference between those two numbers is essentially your driving pressure. The use of PEEP decreases the amount of opening pressure that you need, because if you have PEEP, that means your alveoli is already open before you even start the breath. So clinically, you may be asked to perform something called a recruitment maneuver. This is mostly done on adults, but also can be utilized on a really sick baby. And a recruitment maneuver will require you to use extremely high levels of PEEP. So, of course, we use these on people with stiff lungs. And as you know, neonates have stiff lungs if they are premature, or if they have conditions like RDS and bronchopulmonary dysplasia, BPD, things that we'll talk about when we get to the disease processes of the neonate. So when you do a recruitment maneuver, it requires you to use extremely high levels of PEEP, titrating the PEEP down to normal levels over a short period of time. The key, though, is in order to even start a recruitment maneuver, the patient has to be hemodynamically stable beforehand. And actually looking at the hemodynamic status of the patient will determine whether you need to move faster with the titrating of the PEEP than you might have previously considered. So you might start with a PEEP of 12, even on a neonate, 10, 12. It's higher than the normal level of PEEP. So start with a really high PEEP, and then you, over, say, 5-minute time frame, you go 10, then a minute later, go 8, a minute later, go 6, so on and so forth. There's no hard, fast rule on, what numbers to use. This will all be done by a neonatologist or a pulmonologist who's right at the bedside, who basically will, all of you all be standing there looking at the monitor, looking at the pressures, looking at the waveforms of the hemodynamics, and determining whether the patient could stand the time frame. So if you say, okay, every minute we're going to go down, if within 30 seconds of going up on that PEEP, their pressures start to increase, then you might not want to stay at that PEEP level for a whole minute. You might want to do 30 seconds for each level. So that's called a recruitment maneuver. So opening and driving pressures are very important in neonates. Okay, indications to ventilate a neonate. It's really no different than any other patient you will have, but of course, normalized pH, that makes sense. And here are the ranges here. pH less than 7.20, CO2 greater than 60, PO2 less than 50, that is unresponsive to O2 therapy, and a SAT less than 88%, that is unresponsive to O2 therapy. Of course, babies with apnea is commonplace with neonates. Neonates go apneic. However, if you have a neonate that is having recurring bouts of apnea, that is an issue. So we either need to give some caffeine or theophylline for the apneic spells, and if that doesn't work, they need to be ventilated. Intracranial hemorrhaging, regardless of whether it's a neonate, or adult, or a pediatric patient, if they got ICH, then they need to be on a vent until we can control those pressures in their cranium. And then drugs. If you have drugs on board that depress the respiratory drive, then you're going to want to put them on a ventilator. There are 3 phases of ventilation that you need to remember. The first phase is putting the patient on the ventilator. Phase 2 is monitoring the baby on the ventilator. And phase 3 is weaning the baby off. And this goes for any patient you may have. It's the initiation of mechanical ventilation, the monitoring of mechanical ventilation, and the weaning of mechanical ventilation. We'll talk about the settings and the requirements of each one of these phases next. Okay, for phase 1 of ventilation, the ranges are listed below for what you should set and the mode that you should consider. So for ventilation, your PIP should be anywhere from 20 to 30. We always start at 20, and then we increase the PIP for preemies and patients with stiff lungs like RDS, BPD, things of that nature. The rate is 20 to 40. We always start on the low end with term babies and go up to the high end on low birth weight babies. So term infants will get anywhere between 20 and 30, and babies with low birth weight, 30 to 40, which low birth weight essentially indicates that the baby could be a preemie. You don't have to be a preemie, meaning you are before 32 weeks gestation, 34. If you're before 34 weeks gestation, you're considered a preemie. If you're 34 or newer gestation, you're considered a preemie. However, you could be a 36 weeker and have low birth weight, and even though you won't be considered a preemie, you will be considered LBW, and low birth weight babies, we can use higher rates. Eye time, 0.5 seconds is what we will start with. Low birth weights, we will start with even shorter eye times at 0.25. Your flow rates are anywhere between 5 to 10 liters per minute, and what will determine where you what number you actually use for your flow is to look at chest rise and look at respiratory effort. If the baby is making extra efforts to take a breath, then that means you need to increase your flow. For oxygenation settings, FiO2, we set that anywhere between 30 and 60. But what will determine where you put it is the baby's PaO2 level. So if the PO2 is anywhere between 50 to 70, then you're going to tweak the FiO2 to keep it normal. So normal is anywhere between 50 and 70. PEEP, we're going to start at 2, but it can be anywhere between 2 to 3, but we can go all the way up to 8. The stiffer the lungs, the more PEEP you want to use. If the baby was on any oxygen or CPAP prior to being put on a vent, just like with adults, you will start with those levels. So if the baby was on CPAP of 3 and had an FiO2 of 30%, then when you put them on the ventilator, or let's say FiO2 of 40%, just to keep the numbers to make sense. So CPAP of, I think I said 3, and FiO2 of 40%, then that is what you will put them on when you switch them to mechanical ventilation. So you won't start with the PEEP 2, and you won't start with the FiO2 30 because they were already on oxygen and pressure. So you want to go with those numbers. Lastly, for MBRC, mode doesn't matter. Even with neonates, mode doesn't matter. Any mode is acceptable for initial setup. And clinically, it depends on your facility. What does your facility typically use? That will drive what mode that you will use when you set them up on the vent. Okay, for phase 2 ventilation, we are looking at monitoring the patient on the vent. So we need to be mindful of ventilation problems and oxygenation problems. If the baby is having ventilation problems, we're going to first adjust the PIP to normalize our CO2. We don't want the PIP to be any higher. We want the PIP to be anywhere between 25 and 30 as we're tweaking. We started at 20, but if we are going to be monitoring the baby and increasing our PIPs, we want to stay between 25 to 30. The only time that this is not what the NBRC will have as an option is when the baby has stiff lungs or if it's a preemie. For those babies, you want to, you can go all the way up to 40 of PIP. Okay, so don't be alarmed if they have a question and everything looks good, but they have a really high PIP, say 35 or something like that. They're just trying to bait you to not choose that answer, but that will be the correct answer if you have a history in the scenario of stiff lungs, so RDS, BPD, or prematurity. So if PIPs are appropriate, so you got your PIP where you want it, and it's close to the high end of normal, then going up, say you got a PIP of 30. There's no sense in going up on the PIP unless you have an indication to do so, like stiff lungs or prematurity. So if that's not the case, then you're going to adjust the rate. And you do that by tweaking the E time. When adjusting the rate, you may also have to adjust your flow. If the baby does not have enough time to get that pressure that you have set in, then you have to adjust the flow. You want to speed up how it gets to that set pressure by adjusting the flow. Oxygenation problems. If your baby has problems oxygenating, you want to increase your I time. That decreases your IE ratio, of course, which improves oxygenation. And if you notice, all the things listed here are things that affect your MAP, your I time, your IE ratio, your PEEP. What you're doing is you're adjusting these things, which will then affect your MAP, your mean airway pressure. And because you are affecting your mean airway pressure, you are going to oxygenate the baby better. You could also inverse your IE ratio to help with oxygenation. And this is used for neonates that have decreased FRCs and compliance problems. We also use it for babies whose PaO2 keeps dropping and requires increased levels of FiO2 and increased levels of PEEP, just like we do with adults. When you are finding yourself chasing your tail by being greater than 60 on the FiO2 and high levels of PEEP, then we consider inversing the IE ratio. Same thing for neonates. Lastly, we consider increasing the PEEP when we have a baby with oxygenation problems because, and we don't do it in this order, really. It depends on what is already going on with your baby. I will say the first thing we do consider is increasing the I time, but if the I time is already in an appropriate level, then increasing your I time may not be the consideration. You might be talking about inversing your IE ratio because if you go, if you have a longer I time than you do an E time, then as you know, that's inversing your IE ratio. And it might be PEEP that might be the indicator, but if they have high levels of PEEP already, then increasing the PEEP is not your go-to for oxygenation. So it really just depends on what's going on with your baby. So as it states here, you increase the PEEP to increase the FRC. It also helps with shunting because it will help decrease the shunting. It will help to recruit collapsed alveoli and also improve oxygenation if the PaO2 is less than 50 and the baby is on FiO2s greater than 60. There is a note here, if your MAP is greater than 20, always consider decreasing your PEEP. So with neonates, this is a big one. This will definitely be a test question for you on the NBRC. They'll give you a baby and they'll give you all the settings and all the measurements. And they'll say, it'll be a troubleshooting question. What do you want to do? What do you need to adjust? And if the MAP is greater than 20. For phase 3 of ventilation, this is the weaning phase. Make sure that the reason that you put the baby on the vent to begin with has been resolved. prior to you initiating weaning. Acceptable vent settings to then consider weaning is listed below. So if your baby is on a PIP less than 25, that indicates that they could be ready to be weaned. If their rate is less than 20, and make sure that you are maintaining an adequate IE ratio with that rate of when you decrease the rate below 20. If the FiO2 is less than 40% and if the PEEP is less than 5, then you can consider the patient weanable. And that's when we will start to wean them off. And this weaning is very facility driven. Depends on your facility's protocols, how much you will decrease PIP and rate and all that good stuff. Usually FiO2, as you know, that is going to be driven by your SAT and your PaO2s. Same thing with PEEP. So it really just depends on what your facility does and how quickly they wean or how slowly they wean. So that will determine how much you turn your PIPs down and how much you turn your rates down with each weaning trial. Okay, now we're going to switch gears to pediatric ventilation, which really is identical to adult ventilation except for the ranges that we're going to use to set the vent up. So indications, you already know, neuromuscular disorders, if they have some type of pulmonary disease that's affecting their ability to ventilate, if they were being resuscitated and still are having ventilation issues, so post-resuscitation, and of course if they are in ventilatory failure, which is indicated by a blood gas. Okay, for initial vent settings, we want to set the tidal volume according to ideal body weight, and we use the parameters. It says 6 to 10 milliliters per kilogram and 6 to 8 milliliters per kilogram. MBRC is using 6 to 8. Rate is 12 to 20, just like adults. Minute ventilation is the primary factor that we use in controlling the CO2. And if the CO2 is decreasing, you can either decrease the rate or the tidal volume, just like adults. But the reason why we don't use tidal volume is because we set it to the patient's ideal body weight. And if the patient isn't changing their sex and getting any taller, then they are going to be set at whatever tidal volume you initially set them at. So always make sure that when you are taking your test, that the tidal volume that they gave you initially was set by the patient's ideal body weight. Because sometimes they make you determine what the tidal volume should be, but then sometimes they'll give you a patient that's already on a vent, already on current settings, and you have to be mindful of the tidal volume that they gave you, because if it could be that they're trying to tell you that the tidal volume is too low. They want you to notice that it's too low or too high for that patient based on their ideal body weight. So if you didn't set the tidal volume and it's given to you in a question, always make sure that that tidal volume is adequate for that patient based on their ideal body weight. Okay, for modes of ventilation, SINV is preferred over AC because children do not respond well to controlled modes. It takes more of an effort to get them to trigger the vent. Pressure control ventilation, however, is recommended when the patient requires FiO2 greater than 60 and a PEEP greater than 15 and PIPs greater than 50, and if they have RDS. So of course with neonates we do pressure control, but with pediatric patients we use SINV over assist control. And then pressure control is also utilized when we combine it with inverse IE ratio. And that is it for mechanical ventilation of neonates and pediatric patients.